Hi, my name is Dr. Eunice Wang from the Roswell Park Comprehensive Cancer Center in Buffalo, New York. Menin inhibitors are a novel, exciting class of targeted therapies which are approved currently for the treatment of adult and pediatric patients with two specific genetic or genomic mutations in their acute myeloid leukemia or acute leukemia, KMT2A rearrangements, or NMP1 mutations. These agents are approved in the relapse refractory setting, but as monotherapy only have a CR/CRi rate about 21 to 23% and median duration of response and overall survivals in the range of 4 to 6 months. Therefore, there have been a panoply of clinical trials that have evolved, which are examining combination menin inhibitor therapy for patients both with relapsed refractory and newly diagnosed KMT2A and NPM1 mutant disease. Why do we need these combinations? Well, number one, obviously, we'd like to be improving upon the efficacy and the duration of response for these patients, but also because monotherapy has been associated with the development rapidly of mutations within the menin protein. In one study, it's been demonstrated up to 39% of patients treated with revumenib will develop over a short period of time mutations that prevent the inhibitor from binding effectively and blocking the menin KMT2A transcriptome interaction, thereby negating the efficacy of these drugs. This may account, and again, for different mutations or different mechanisms of resistance for the very short duration of response that we see with monotherapy. The other rationale is because we see in patients treated with menin inhibitors as a class, the clinical development of differentiation syndrome, which can, in some patients, be severe and even life-threatening. This is characterized by respiratory compromise, life-threatening pleural pericardial effusions, fever, weight gain, hypotension, liver failure, kidney failure, etc., and occurs in up to 20 or more % of patients. The initiation of steroids as prophylaxis and other mitigation strategies have really decreased the severity, but in combination, we think that chemotherapy backbones can negate or significantly reduce the risk of differentiation syndrome by providing cytotoxic effects that directly eliminate those cells and prevent the release of cytokines contributing to that clinical syndrome. Therefore, we are very much looking forward to the results of currently menin inhibitors in combination with both intensive and less intensive therapies. Early results from relapsed refractory and newly diagnosed cohorts of many of the menin inhibitors, revumenib, ziftomenib, and zilmenib, and bexamenib have shown very high rates of response, prolonged overall survival, and, as we speculated, decreased risk of differentiation syndrome. Although we haven't completely removed the risk of development of menin mutations, we're looking forward to evaluating which patients may benefit from menin inhibitors in combination with chemotherapy backbones in the very near future.